fella. Lagos never gonna be the same. Never without fella. Lagos never gonna be the same. Never.
Good evening, everybody. My name is Linda Johnston. I have the honour and the privilege of being the Dean of the Lawrence S. Bloomberg Faculty of Nursing here at University of Toronto. And I'm absolutely delighted to welcome you all to our Nursing Week keynote event, featuring our esteemed and honoured guest, Professor Sheila Tlou. Before we begin, I wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still the home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work and learn on this land. This is Bloomberg Nursing's first return to an in-person celebration for National Nursing Week. And I'm really thrilled, yes, let's give ourselves a clap. To have you join us today, including those of you who are able to join us online. Nursing Week at the Faculty of Nursing has always been an important opportunity to recognise the impact of our global nursing community. It is also, of course, a time to celebrate and to acknowledge the hard work and the dedication of those in the profession and to provide them with the recognition that they deserve, which in our view also includes recognising their leadership in the face of global health crises and their advocacy and innovation in the face of social injustice. In preparing for our Nursing Week events, we drew inspiration from this year's International Council of Nurses theme, Our Nurses, Our Future. We felt that there was no better person to speak to not only the future of nursing on a global stage, but also the impact of nurses in striving for global health equity than Sheila Tlou, Chancellor of Botswana Open University. Sheila's accolades are many and more than I can name here today, although she is also known as Honeybee in recognition of her constant busyness. Her multifaceted career as a nursing leader and advocate has taken her to places all over the world, earning her the title of one of Africa's 100 most influential women. But her most notable contributions have been in the regions of southern and eastern Africa, particularly in her home country of Botswana, where she's played a key role in the development of national nursing and medical education curricula, broadening the scope of health sciences education for nurses. Appointed Minister for Health of Botswana in the mid-2000s, Sheila has also made it her mission to bring about a drastic reduction in mother-to-child transmission rates of HIV/AIDS, utilising community nurses to bring about changes in stigma, testing and practice. She's not one for slowing down and has now turned her attention and advocacy to the fight against malaria, becoming the Special Ambassador for the African Leaders Malaria Alliance, in addition to her role as co-chair of the Global HIV Prevention Coalition. It's my absolute pleasure to invite my colleague Sheila to the stage to share with you all her journey and her thoughts on the role that nurses play in bringing about impactful change in our fight for equitable health for all. Please join me in welcoming Sheila.
Thank you, my dear. Thank you very much. Let me also recognize and pay homage to the ancestors of the land on which we stand, and to say how happy I am to be with you. You all look great, and I want to greet those who are joining us virtually to say I'm hoping that you'll also be able to pose in your questions. There is no way I can cover a lot of what I want to say in just a few, in an hour. So I normally want to speak and then leave time so that we can discuss. This should be a discussion. We all learn from each other. So I want to thank Dean Linda Johnston and the faculty and the staff of the Bloomberg S. Lawrence, or Lawrence S. Bloomberg Faculty of Nursing for inviting me here all the way from Botswana. I arrived 2 days ago and was welcomed by none other than the Pan-Canadian Association of Nurses of African Descent. So it was great, and one of them is right here. The executive is represented by none other than Dion over here. So it's great that I learned quite a lot from them. And I know tonight I'm going to be learning quite a lot from all of you. We learn all the time. Learning does not stop. So just to say that I've been here since Sunday, so jet lagging is on and off, but I think I'll manage. And it's not my first time in Toronto. I've been to Canada many times, including at the International AIDS conferences. But I like Toronto apart from the weather. But I've brought good weather, so I can't complain. I did bring good weather. When I came, it was cold, but the sun had decided to come out. So I think it was really recognizing that this woman needs more sun. So it's great to be with you. And, you know, it's great to be able to share what I have. So there I am. I really am using the current ICN slogan, the theme for this year's, Nurses Day. And let me say Happy Nurses Day to all of you and to those who are not nurses. And Happy Nurses Week. For Nurses Day, I'll be in London giving out an award that has been established by the Asta Global Health Company for what they call the best nurse in the world. We had about 600,000 entries. They give it out every year. And, the nurse who comes out, you're supposed to talk about yourself. And this is so unlike nursing, because nurses don't want to talk about themselves, right? Yeah, but this time we force you to talk about yourself, what you are doing in the area of education, leadership, practice, just your area, and say why you have to get the award. And it's 250,000 smagaroons, like US dollars. So we'll be giving that on Nurses Day, on the 12th of May in London, to the best nurse. We normally have like 10, and I'm in the grand jury. I wish they had given it to me, but they decided, no, you probably will get it, but so you have to be a juror. So as a grand jury, I'm okay. Yeah. So, okay, there I am. I think Dean Linda talked about that. I'm a co-chair. I'm retired. Basically, I'm a retired human being, but not tired. So I find myself, after I retired, I was told, you did a good thing in bringing down HIV infections. So we want you to chair a global HIV prevention coalition of countries that are contributing to new HIV infections. That's what I'm doing. It's supposed to be 30% time. But sometimes they tell you 30% when it's actually 60. So anyway, it's 30%. And then I was appointed Vice Chancellor of the Botswana Open University. That's also a titular head. Normal chancellors used to be our presidents, but then as universities became too many, it was more like, how do we, let's give it to some of our noble people. So I'm the chancellor, and it's really the titular head. I attend graduations, I advise where I can. So it's not too bad. But the African Leaders Malaria Alliance is the one that's really saying, combine the Sustainable Development Goal 3.3, which says end the epidemics of HIV, TB, malaria, NCDs, and the neglected tropical diseases. So basically, that's where I am. And I'm enjoying myself, making sure that people are aware that there are neglected tropical diseases. I call them diseases of neglected people, because of the time, our leaders out there are not aware of them because they don't happen to rich people. They happen to poor people. So that's where advocacy starts with me. Okay, so let me see. I've been told that if I move, come and assist. Oh, yeah. I've assisted. All right. Thank you very much. So, I have, this is going to be a conversation, but those are my main themes. Let me have some water here. I'm so important. I got 2, all this water is mine. Oh, wow, that's nice. But it's ready to look at the theme of our nurses, our future, which I'm sure a lot of you are already familiar with, and the guidance that we've received from ICN in terms of how do we then advocate for nurses, the well-being of the nurses, the retention, and really ensuring that nurses are well recognized in our various countries. So I'll be looking at that using looking at the global health challenges that threaten health for all, and identifying aspects of nursing in global primary health care, universal health coverage, achievement of the SDGs, but also share my own personal experiences in nursing advocacy. I see myself as an advocate. I'm still an advocate. I'll probably die an advocate. And I like advocating now because I'm at the age where I can say anything to anybody and get away with it. So it's really great. So it will be also sharing ideas on what I think we need to do in terms of gendered health policy reform and really focusing on the future of nursing, what we think, and global health. But the end product of this is really to say nursing has a future. We have a great future. The shortage that is happening now is really showing all our leaders everywhere that they cannot do without us. It's not a question of nothing for us without us. It's a question of nothing for the world without us. So let's see how we do. Yeah. So anyway, but the global health challenges, I think we know all of them. But I really want to look at the legs. We have the global emergencies, fine. The natural disasters, including those which are made by men, literally men who had pens. But epidemics such as HIV/AIDS, and we'll talk about that, especially the COVID-19, because that's the one that made people the world over realize just how important nurses are. And that's important, how important health personnel are. I think it's a lesson that I'm hoping doesn't get to be forgotten very soon. Remember we had COVID, and it's almost like now we've actually forgotten, well, we're glad it's over, but it's almost as if the effects of that sometimes we forget, except when you look at how it has actually devastated economies. So we're also looking at human resources for health. It's the shortages. Everybody has their own estimation. Right now, the estimation is that we are 8 million short. But WHO and ICN are saying if nothing happens, the global shortage would be about 13 million nurses. And these are not replaceable. So let's see, as we talk, we'll be able to see what then we need to do. But let's look at the lacks. Here is the lack of protection of human rights for women and girls. And most of the girls are women, right? So if you are looking at that, the gender equalities and all that, nurses are particularly affected because the majority of us are women. So key populations and other vulnerable groups, whether it's the elderly, migrants, indigenous people, and people living with disabilities. But what really we're here for now is the lack of investment and prioritization of the safety, the health, and well-being of nurses throughout the world, not just nurses, but other healthcare workers. People usually say, well, is healthcare prioritized? I say, well, it's prioritized in a lot of countries. But guess what? You actually got to know the configuration of any one country in terms of how they prioritize health by looking at how cabinet sits. When I was a minister, the president would sit here. Next to him would be the Minister of Finance, then the Vice President, the Minister of Minerals, the Minister of Energy. Now, I was like over there with the other ministers, education, local government, just to show you that, yes, these are the service ministries, but sometimes because, especially in a country where these services are given for free, you are seen as somebody who's accepting money from the government rather than contributing money. So you find that you are not quite as important as the Minister of Finance or quite as important as the Minister of Minerals and Energy. So health has always been looked at that way. We only have a problem and we want to do a lot more when there is a real, natural, or what should I say, global problem. That's when we're saying, yeah, health is important. But before that, we just look at it like, yeah, we take it for granted. So anyway, but that's despite the fact that the nurses are there, and they're simply saying we have already proved ourselves. We play a central role in universal health coverage and primary health care. So nurses have excelled in the fight. I mean, nurses showed themselves during COVID as that formidable force that can take care of humanity in all situations. And we were so praised. I remember, every evening we'd be seeing on TV the various countries, how they'd come out and be clapping for the healthcare workers. And we are looking at them saying, could you advocate so that when this is over or right now, that they have better living conditions, better salaries and all that? But no, it was like, we thank them, they're okay. So that's where we are. But the worldwide nursing shortage is a threat to health. And it's also a threat, I say, to global health security. In that, if you look at countries right now, developing countries are actually blaming the developed countries for the brain drain. Yeah. It's like that, they're taking our nurses, they're doing this. We train them, we're educated, we used our money. But the point is, if people are not satisfied with where they are, and they are not recognized, they are not valued, they have that right to move. I served in with the former president of Ireland, Mary Robinson, and we came up with what we call the Global Code for recruitment and retention of our health personnel. And in that code, we stated very clearly that health personnel have the right to move. That's a right. Nobody should say, we are going to prevent them from moving. No, they have the right to move. However, once they have moved, in the receiving country, they should have that right to be treated in the same manner as the health personnel of that country, in terms of remunerations, in terms of housing, all the perks they should be able to get. So that was really our advocacy. But a lot of people now come over and say, yeah, but Sheila, you already didn't do it. You should be penalizing the Western world for taking our people. It's like, no, the least we can do is to collaborate and ensure that we produce more nurses. There are lots of young people out there who need to be trained, but we don't have the personnel, we don't have the faculty, so we could collaborate. That's basically that. So, but for us though, we do have some key documents that as nurses we need to look at and be able to really understand, and also to use them in terms of advocacy. One of them is the State of the World's Nursing Report, because that one was global, commissioned by the IC and WHO. It looked at the status in terms of nurse-patient ratios, in terms of what are the employment benefits like for the various communities, and they had perfect recommendations there in terms of the education of nurses, also nurses as independent practitioners, more nurse-led clinics, more. So it was really, and then of course the nurses in leadership positions to say we need more nurses in those positions where they can be able to make decisions, because they can make better decisions then for healthcare, whether we are looking at community healthcare or even hospital healthcare. So us as nurses, we need to be advocates. Nobody is going to do it for us. We have to do it for ourselves, and these are the key documents that we need to be able to do, to look at if we are going to advocate, with our leaders or with our whoever, even at a community level, to be able to just say, let's see what we can do. How do we improve the health of the world? By improving the status and the profile of nursing. That's basically what that was all about. Now, for me, my religion has always been primary health care. An advocate under primary health care. I finished nursing in 1977. And a year later, the Alma Ata Declaration came into being, Health for All by the year 2000. Now, this was a global health agreement in Alma Ata. And to me, it is relevant. This was in 1978. It's relevant now as it was 45 years ago. Why? Because it was looking at healthcare that should be accessible and really universal, with the emphasis on maternal, neonatal, and child health, and that communities should actually be there in addressing the social determinants of health. It caters for the neglected groups. As I said, there are so-called diseases of neglected people. And indeed, during primary health care, when it was being implemented, a lot of the schistosomiasis, chikungunyas and all that, they were had because people knew that we need to get rid of those diseases. Now nobody is saying anything about them, and they're still there. And guess what? Even the disease of the Bible, leprosy, is there. And you're thinking, really? We still have leprosy. So we need to be able to act on that. But the great part was that during that time, the nurses and the midwives were the backbones of delivering primary health care. So it was for countries like ours, especially developing countries. We had the nurses, we had the nurse practitioners, we had the family welfare educators, and it was a great success. But I went in that interest, but coming on it from the human rights and gender perspective. And I remember questioning why we are saying maternal, newborn and child health, when in fact we should actually be taking care of women's health from the womb to the tomb. So, one of the things I remember asking our minister was, so if a woman is no longer bearing children, she's no longer wanted. Or if a woman is not yet bearing children, she's not wanted. Why are we neglecting adolescents and also menopausal women? They need healthcare. So it was really coming from that angle. But, there are certain lessons. I have 3 lessons that I want to share with you, what I learned from primary healthcare. The first one is really that health is made in the home. Hospitals are for repairs. And that to me is that religion. So as a researcher and gender activist, I was able to generate knowledge and to document the impact of HIV and AIDS on people, but mostly on women and girls. And this kind of evidence led to programs for women and by women themselves. But also as an educator and WHO kind of collaborating center director, this was the World Health Organization Collaborating Center for Primary Healthcare Development for Anglophone Africa. That's 25 countries. But because there was no collaborating center for Francophone, it actually became a collaborating center for everybody. And therefore, I was able to use that knowledge and make sure that I influence change among the nurses who are coming from the various parts of Africa to say we need to do something about the gender aspects of HIV and AIDS. And when I was with that, I wasn't aware that actually later this thing will come out where they then became ministerial AIDS coordinators. So by the time I became a minister, in Botswana, in a lot of the Southern African countries, the nurses that I had educated at master's degree level on HIV and AIDS and research were actually ministerial HIV/AIDS coordinators, not just Ministry of Health, but other ministries, because it was then decided that every ministry, whether it was agriculture or finance, should have an AIDS coordinator. So we had nurses there who were at director level, and therefore as coordinators, and influencing change. So it was to me one of those serendipitous things that it was like, wow, it's great. They're right there, yeah. And being a community activist, I had to also do interventions on HIV prevention. And indeed, I want to emphasize the thing of documentation. Because, as nurses, we do a lot of things, but we don't document. And it is important that whatever we do, we should document it. And we must disseminate it. Even if it's disseminating in a newspaper, it's still dissemination. Somebody is bound to look at that, is bound to touch somebody, and there's bound to be some change because of that. So it's really that, that when we're documenting some of these community events, it was a great source then of support for me when I became a minister. Now, there are some of my master's degree students who were educated in HIV/AIDS, and this was their graduation. So, we did quite a lot. Now, the advocacy as a political leader, remember I did say I was always an advocate, even when I was making decisions. In 2004, I was appointed Minister of Health, but somebody asked me, how did you, what happened? Because of what I had written, because of my advocacy, being an activist and all that, it was partly to say she knows what she's talking about, but it was also to say, shut her up. Let her come over and say, how you're saying, the government should be doing this. The government, just like, let her come over and be the government and see what she can do. So, and the great part was that at that time, we had very few medical doctors. As when we had the dean, when she introduced me, I was responsible for coming up with the medical curricula. So by the time I became minister, that's when the medical school started. So we had very few doctors, but we had very well-educated nurse practitioners, nurses, midwives, and community healthcare workers. And with them, we used applied research and just made sure that we partnered for health and AIDS. And it was really that. But the great part was when the president asked me to come and be Minister of Health. The African leaders had just said that they were going to debate to have 15% of the health budget, of 15% of their budget towards health. And none of them had done that. So part of my advocacy had been to go to other countries to say, has your president put 15%? Where's the Minister of Finance? 15%, where is it? So when I was asked to come and be a minister, I said 15% of the budget. Otherwise, I'm okay at the university. I'm not coming there. And he, President Mugai was a very great guy, and he said, actually, I'm giving you 22%. But I want a report every 3 months. I called together civil society. I called the nurses together, and I said, guys, we have money. Let's roll. And we did. We did. We did to the point where, as she said, mother to child, within 4 years, we had almost covered the people who needed ARVs. Mother-to-child transmission went from 29 to 8%. Right now in Botswana, it's less than 1% because they continue with that. And, we also saw maternal mortality due to AIDS coming down to less than 4%, showing that, when she leads and she is a nurse, great things happen. I was under pressure to do that. Why? Because I was the first nurse in Africa to be made Minister of Health, and probably like the third in the world, so that we needed to show that nurses belong everywhere. And where we are going to be capable because we are the ones who are more in touch with communities than anybody else. So I shared what I was doing with ministers in resource-limited settings and actually wrote that to say partnerships with nurses and other stakeholders. Because, some countries were at a standstill. We can't roll out ARVs because we don't have doctors. They are the ones who are supposed to prescribe, to do, and it's like, no. We have nurses, we have nurse practitioners. They prescribe, they follow up, and the adherence level there was more than 95%. So it actually was that. So, but one thing that was also learned, indeed, because of that, what I just said, has been that health is a political choice. The people that we vote in we better vote in people who really know, who love health and all that. Half the time we vote in somebody because they look good, or they've said something really good, or they're rich, like Donald Trump, But really, we need to be able to say, what is it that you have for us? So health is a political choice, but where politicians have solid evidence, they can actually be able to, they can do a lot for nursing. And we can see them doing a lot for universal health coverage. When we, as practitioners, as ministers, we were able to show how having more family nurse practitioners actually is really beneficial. To the point where if you look at, like right now, 75% of African countries actually have advanced nursing practice roles compared to only 53% in the outside world. So that it's really, and we have retained them, because what then happened was give them, they should be remunerated. They should have better, healthcare. They should be, give them all the incentives to stay. And indeed, quite a number of them have stayed. But we need, therefore, also collaboration and partnerships in our academic and clinical practice. We have in Southern Africa what we call the East Central and Southern African College of Nursing. And we are now working at political level to just say, look, we need to collaborate. This college, because already it encompasses a lot of countries, strengthen it for nursing education so that we can produce more faculty, we can produce more nurses, and be able to share around. And I think that's what we need to do. So, but really, also to just say, when we have done research, we are able to give that research as evidence, and usually, evidence hits you on the face and you cannot get rid of it. So you find that leaders are then able to do that evidence-informed practice. For example, the fighting that a lot of us went through over having chief nursing officers. If there was no real reason why you wanted one, you didn't get one. But where you had real statistics to say, if we could have somebody who's responsible for the whole area of nursing, at that level, at a higher level. But not only that, some people actually got that, but it was only that one person. And you can't do much if it's one person. So I've usually said to my colleagues, when you are advocating for that, make sure that you are saying this person should have an office and personnel to be able to do their work, rather than just one lonely person in there. In fact, in Botswana, what happened was, because when immediately I was appointed, a lot of the nurses were really eager. Oh, now we have one of our own. We need a chief nursing officer. The position had been abolished like maybe 10 years before. So I said to them, no, let's look at this. If we advertise positions within the ministry and we ensure that nurses are there, then later we can be able to advertise for a chief nursing officer position. Because if we fill this one, later when we want to fill other positions, they're going to say nurses are already represented. So we made sure that the director of research was a nurse, because when we advertised, if you look at the way people advertise, they want a director of public health, and they advertise a junior degree, requirements a junior degree in medicine. And we're thinking, why? And then they go a senior degree in public health. What if there's a nurse who has that public health degree? What if there's a pharmacist who has that public health degree? So we just say a junior degree in any health field, a master's degree in public health. And we were able to put nurses in really strategic positions within the ministry itself, as directors and all that. And then we said, now we need a chief nursing officer. So that even if that person came in with like 4 staff members, she had the support of all the others. he or she had the support of others. So, and that's what I was, going around that for telling other ministers to say, this is the way we should do it. But then, of course, some of the ministers were not nurses or health personnel. So to me, they were looking at me like, she's got to be crazy. But this is one of the people that this is His Majesty, the King Mswati of Eswatini. This is the one person who I've had to do quite a lot of advocacy on with nursing, because Eswatini is a very traditional society. There's nothing, gender equality, we don't think so. So it meant going there quite often to be, this is what the one, in our situation, this is one country where a man can marry many wives. So even when it came to HIV, going there to just come up with messages that are suitable for the country was something else. Where we are able to say, when we are educating, avoid AIDS, be faithful to one partner. You can't say that in a polygamous space. So we had to say, be faithful within your polygamous. And it was like, oh, okay. But he's a great ally. Even in malaria control, he's really one person that I work with very well. He's been able to do quite a lot for his country. So, but it just shows, the work, the advocacy work has been mostly with heads of state and with ministers. So the last thing that I've learned with primary healthcare is simply to say global health equity is the future of humanity. The COVID pandemic, the silver lining for me, is that it showed us that we are branches of the same trees and we are leaves of the same branches. No country is safe until all other countries, and until every country is safe. So that it therefore behoves us that we should have global collaboration among leaders and among health personnel, especially nurses, to say, how do we avoid future pandemics? How prepared are we for future pandemics? Are we going to treat it the way we treated COVID, where the West had all the vaccines and we in the North had nothing? We had vaccinations up to 70% here, when in a place like Africa, we had only 3%. So somebody says, well, how did Africa have often had this question, how did Africa fare? How come you were not affected that much in terms of deaths? I said, you know what? I think it was just God. There is a power out there that was acting. It was not a human being. Because between our leaders who had no clue and the Western world that didn't care, we could have been decimated. In fact, the estimation had been that Africa is going to disappear. But guess what? God intervened, and we didn't. In Botswana, we had only like 1,000 deaths. So it was like, okay, we're right there. So, but we don't want that to happen again. So we need to be able to collaborate better, and who better to do that than the nurses? Because we have really shown ourselves as that force that can take care of everybody in any kind of crisis. So advocacy, even now for this campaign, has been that nurses are catalysts for global equity, and we need meaningful global investments in those areas. So in terms of education, in terms of jobs, in terms of leadership development, I usually say to nurses, if you are not at the table, you are on the menu. So just make sure that you are right there where decisions are made, or they make those decisions without you. So I'm not going to go this one, the Nursing Now and the Nursing Global Challenges campaigns, because this happened in 2018, just before COVID hit. But these are the campaigns that really have led to other campaigns, even the Now campaign. In that, I was co-chair of this, and the main thing was really to say, look, we need to profile the status of nursing. We need to be able to say there will be no universal health coverage until nurses are properly educated, properly retained, and indeed, we make sure that all the challenges are taken care of. So now we have the Nursing Now Challenge, which is looking at young nurses, young nurses under 30 to say, let's look into the future. Those of us who are now older, we are saying the future of nursing is here. How do we ensure that we retain them? How do we ensure that they stay in nursing? And my thing for them, the young people, those of you who are young out here, is to say that the Sustainable Development Goals are actually your niche. There are 17 Sustainable Development Goals. The third one talks about health and well-being. And a lot of people concentrate on only that one. But we have zero poverty, zero hunger, education, gender equality, even life under the sea. We need a nurse in each and every one of those. Because my belief is that the way we are educated, we fit everywhere. And the way we are tenacious, we can be able to make that impact in whatever sustainable development goal we're looking at. So it's really my exhortation to young nurses to say, be introspective. Determine what your future experience is going to be like. Because it's okay for those of you who are in the clinic area, in the hospital area, yes, it's great there, but there's also the need for nurses out there, especially in the Sustainable Development Goals. It's really that. And to say to them, when you are in there, you will be with other actors. Remember, the sky is not the limit. You can go further. Most important, remember that there is nothing like a glass ceiling. It's actually just a bunch of men's bodies that need to be moved. You move them, you're able to see. That's all. Yeah. So it's so that nobody should tell you that. We are right there. And so I'm left with just a few minutes, but I want to conclude by saying that leadership or advocacy for nursing and global health is our mandate. And it simply requires us to do research and have data to promote excellence and just influence, for more innovative and cost-effective nursing programs. We need to collaborate, not just among ourselves. I don't particularly like it when I see nurses doing research and it's just their own little cocoon. I usually say, where is the social scientist in there? Where is the education person? So that it's broader. And when it's broader like that, it influences change better because you can be able to disseminate it. And I usually say when you now have to give it to a congressman, make sure that whatever you had that was 15 pages, condense it into 2. They don't know how to read. Yeah. Just may have 2 pages that are saying what you saw and what you think can be done. That actually works. We've seen it working quite a lot, especially with our leaders. And we need to strengthen community systems. But most important, as nurse leaders, those who are here as nurse leaders, we need to mentor the leaders who are here. We need to mentor future leaders. That's the only way we can sustain ourselves. As nurses, when I was going to school, in my days when I was a student nurse, there were nurse leaders who were believed to be eating the young. I mean, they were that terrible. But we no longer have those. We have the Lindas, So, get to them. They should be able to mentor you to be where you are. And we need to be able to do that. So it's basically that. My last thing, usually, I say to nurses, you need to be where decisions are made. When we grew up in nursing, we were told that nursing is apolitical. Remember that thing? Yeah. And I've had to explain to them to say, no, it meant you don't align yourself with any one political party. But what you are doing now is very political. And it will become even better political if you can say, I want to go where decisions are made. I want to make that difference. When I became minister, a lot of young people, especially young girls, To them it was like, I'm going to be a minister. And we said, no, okay, go to school first, then you can be a minister. But not only that, we had nurses who then decided they're also running for political office at county level, as councillors. And I tell you, I had 2 nurses who became mayors of 2 towns in Botswana. And their towns, I saw the infant vaccination rate go from where it was in the 80s to like 100%. I mean, they did such a good work. I would say when she leads and she is a nurse, great things happen. So let's one day have a nurse who can be a president and will say, when she is a president or he's a and he's a nurse, the world actually moves. So with that, is simply to say, let's get there and go where gender-responsive policies and services can be done. And especially for you, the ladies, men will never speak for you. They never did. So if you want gendered policies, let's get in there and dust our hands and make sure that we participate. So with that, thank you very much. I'm hoping we've been able to share, and I'm looking forward to questions. Thank you.
I'm not entirely sure how to follow that. I'm tempted to just leave us all with that ringing in our ears, particularly the men's bodies, to get out of the bloody way. But nevertheless, in my professional role as facilitator and moderator of this fantastic session, we do have an opportunity for some questions from the floor or from those of you online. And we have people wandering around with microphones. So welcome thoughts, comments. Dion.
It's on, but
Yep.
okay. Thank you so much.
How are you doing?
Thank you so much. My question is, I know several nurses who've left the profession. They left because of COVID, and some are leaving now. Their bags are being packed right now. If they were here, I think they would probably put down the bags and come back. But what recommendations or suggestions do you have for those nurses who have left because they were fed up and burnt out and just tired, to say, no, we need you, because when nurses lead, so much more happens?
But have they left nursing completely? Or they've left the situation where they were maybe not happy and they are going to another place?
I know 2 selling real estate and another one selling high-end cars. And they're doing very well, actually.
That's the SDG of gender equality. They're not in there where men are. But the point is, as long as they're not leaving because they are so disgruntled that they don't want to even see nursing, completely. But I guess in the ultimate, it's simply saying the leaders of nurses, we need to mentor more. We need to give that support. When somebody finally decides that it's one thing when somebody's saying, I'm leaving Canada, I'm going to work in America. That's a different story. They are going for greener pastures. But where now they are living completely, that's when you get concerned as to, where their mind and heart in there in the first place, or they just got so disgruntled that they don't want to have anything to do. But then I guess in the ultimate, some people will leave. However, we need to prevent that and ensure that we really, mentor our young. Yes.
Doris.
Yeah, there's Doris behind you.
And then OVA.
Thank you. First to Leader Dion. Nurses in the mid-30s, in terms of not mid-30s, but 30-year-old, so always there was a percentage that left. I think you're right that now it's higher. I think it's too soon to know if they will not come back. I know many that came back already. So let's not lose hope. And I think if they will work with people like you, they will all be back. And I mean it, and I mean it, and I mean it. A question about funding when you were minister or any time after.
Yes.
Funding for social determinants of health, i.e. social portfolio, if was not the same minister, versus, housing, education, minimum wage, etc., and funding for healthcare. How do you manage both? Or what do you advise?
Well,
Because we know as nurses that social determinants have a huge
I think
impact.
I would say it needs a collaboration between the ministers. Because, when you are a minister, like you are given health, sometimes, let's say even when you are dealing with young people, you find that there's also a ministry that's dealing with young people, the Ministry of Youth, another ministry. So it means collaborating and getting, they act together and making sure that the funding is actually pooled to prioritize on what needs to be done. So that's what I would do. I used to do. Like when we needed housing, the person who was in charge of housing would sit together and say, look, we know the teachers need to be housed, but also the nurses. And these are the people that need to be right where the people are. So how do we prioritize in such a way that at least where you want to put housing is where there are more hospitals or there are more nurses who need that housing. So you are never given the money, it's given other people and you just have to collaborate.
Got it.
Yeah.
And so in addition to referring to housing for nurses and benefits for nurses, what about housing for people that are indigent, people that are suffering social exclusion? So I'm talking about the population as a nurse. So you know the work of RNO, so we advocate for both, right?
Yes.
But when our premier needs to look at both,
Yes.
then the question is housing. What does this to do with nursing?
Yes.
So how do you help governments to understand that it's not either or, that it's both?
Yeah,
And in fact, at the third pillar, which is environmental health.
The environmental health, yes. That is important. But actually, it really, as I said, says to how different ministers work together to ensure for the common good. Because sometimes everybody is cooking their own little pot. And you're thinking, but we need to collaborate so that as we are looking at housing, we can say, let's prioritize this. Let's go to this particular town. Maybe that's where more people need housing. Let's go to this. Maybe that's where there are more people there with disabilities. So it's basically that. And that's what we were able to do. Even when we were changing laws, I had to work with the Minister of Gender and the one for Public Service to say there's a policy here that is very gender insensitive. And we'd work on it together and push it through Parliament. But when we came as a group, then it's a whole lot nicer than if you are alone. You look like a radical if you are alone. Yeah.
OVA, did I see your hand up?
So thank you for a very insightful presentation. I think particularly for me, sharing that the 17 determinants of development, sustainable development, is an important way for nurses to see their future. But one of the things that stood out to me more than that was within our profession, we talk a lot about mentorship. We talk a lot about nurses eating their young. And in my leadership position that I currently do, and just speaking to various nurses, that is something that currently still happens. It's not necessarily my experience. I guess personality sometimes dictates experience. But how do we as a profession actually look at that as a retention problem and shifting that the culture of nursing should be more welcoming? And one more question is, how do we informally create mentorship in a way that is informal, that supports young nurses coming in and feeling welcomed into the profession?
And I think after COVID, it's even more important because remember there were some nurses who missed their whole practicums because of COVID. So right now, and I heard that this is happening also here, where in some hospital, they've actually had like a 6-month thing where, they are able to then put these students, once they've graduated, in to just make sure that they orient them and they make sure that they are now used to whatever environment, whether it's hospital, clinic, or whatever. So I think that's actually mentorship. Right away thinking, what needs to be done. I mean, somebody could simply say, let them come in, and then of course they make mistakes and they get the brunt and all that. But it's that kind of mentorship, but also the one-on-one where you're having a senior nurse, be able to work with junior nurses to just make sure that they get encouraged and they're comfortable in that space. So it's something that needs to be arranged, whether formally or informally, but there has to be that mentorship. Yes.
My colleague from McMaster, and then my colleague from Sunnybrook, and then I think there's a question online, and then we might have to come to a close, I'm afraid. So, colleague from McMaster?
McMaster, she's one of my own. I was so happy to see her. She's from Botswana. So
Hi, everyone. I have to first start by admitting that I'm actually not a nurse.
Yes.
But I am a global health student. But one of the things that I've been thinking about as you were talking was about the brain drain, which is getting worse, not just in the nursing sector, but across all sectors, and that's having a very profound impact on just standards of living in lower income countries. So I think that there's, in one aspect you were talking about, like, yes, that you can't prevent people from leaving, and that's just an actuality, because if people want to go to towards greener pastures, they're well within their right towards that. But understanding the deficit that leaves in lower income countries, what are some things that our governments should be doing to keep people there, and also to be incentivizing young people like myself to be coming back to Botswana to add to how we can create a brighter vision of our continent so that we can be more self-sufficient. So my question is really revolving around the brain drain, especially now as a result of COVID, understanding that it's getting significantly worse,
Yes.
right? So it's just really about general thoughts and probably advice that you can give to younger people, such as myself, who are who are living within, the global north. How do we reframe the idea of home being greener pastures?
Yes, and you are, but the great part about young people is that I found that most of young people want to work at home. Nobody wants to work outside. Those who are home and get to be satisfied, they want to work at home. But the conditions have to be in such a way that, they cannot be then posed outside. So I work with government to simply say, look, salaries are meant to be used where they are. Nobody is going to look at the pound and say, in Botswana Pula money, there is so much, when they know that actually when I get to London, I'll have to be using those pounds, and I'll probably have very little left at the end of the month, in the same manner that I would have very little left at the end of the month in Botswana. But there has to be housing. There has to be career progression. All the things that sometimes don't even cost a lot of money, but they should be made available, and you'll find that young people actually stay. When I was a minister, that's basically what I did. I was to work with other ministers, Minister of Transportation, Minister of Housing, to say, let's have housing. And I actually went to, because a lot of our doctors who had started being trained, and nurses were in Ireland. I undertook a trip to Ireland and told them, come home. And they came. The problem is, as somebody said, nurses do eat their young. When they came, there were some people who were looking at them like, so how's the pound? It's no longer effective. Huh? They were being given attitude, but at least they were now home. And they were telling me that we are home, but the reception is there, is great. Sometimes the reception is not that great. It's almost like you betrayed us by going away. And therefore, you have to pay. But they came back and they've been back home. So that it's real basically to say, let's make sure that in every country, our health personnel are valued. They are, given all the necessary care to make sure that they're at home. Yeah. Even just health care. Sometimes nurses don't even have insurance. Yeah. But we need to ensure that the carers are cared for. So during the COVID pandemic, for example, they're not the COVID, during HIV, I had special wellness centers for health personnel so that they can get their test anytime and come back and be into us confidential. Had I simply taken that they'll go to the voluntary counseling and testing, first, they don't want people to see them over there. Number two, they don't even have the time to be. So it had to be brought to their own, and so that they can have that counseling or whatever done right there. So it helped quite a lot, yeah.
Rue, and then I'm going to give the last comment to a colleague online.
Okay.
Thanks, Rue.
Thanks so much for your presentation. So my question is related to the work that you did in Botswana and how we can learn from that as it relates to influencing governments and policies here in Canada. So now more than ever, given the nursing shortage, we need to be able to advocate for our profession to government and to be able to say to them, by focusing on nursing, they will have an impact on outcomes for patients. How did you achieve that in Botswana? What exactly did you do that helped to increase sort of healthcare outcomes for patients and make it better for patient populations?
Well, as I said, it was evidence. You know, when you are talking, you are advocating, and you don't have, you haven't done research, you don't have the evidence, it doesn't get that, accepted. But if you have collaborated with others, and you have that evidence, and you are showing it to whether it's a politician or even a chief, because you also need allies in high places. When I was doing this, I had the chiefs. Now, in my country, and of course, we've been to Africa, in African countries, the chiefs are more influential than politicians. So I had them all right here, and in fact, I saw the power that chiefs have in influencing policy to the point where later when I was regional director, I managed to stop child marriages in 3 countries using just chiefs, not politicians. And up to today, child marriages have stopped in those countries. Yeah. So we have to really look at where your allies are. Friends in high places. Yeah.
Rebecca, you've got one last comment from somebody online.
Yes. Can you hear me?
Yep.
Okay, so this is from Anshumi Joshi. She says, how do we dismantle power structures that influence policy decisions, not necessarily backed by data, but instead based on self-interest? So I think that's a bit of a broad question.
Based on self-interest. I wonder what that means.
So dismantling power structures
that influence policy decisions. That maybe
that are not necessarily data-driven policy decisions, but rather the self-interest of the decision maker.
Yeah.
Oh, I see.
Right, those who invested for themselves.
For who invest, for themselves.
Yeah.
But isn't that what we have that, right now? We do all the time. If you look at right now, some of the leaders that we elect, we don't even know what their political stance is when it comes to HIV. To health or to nurses, for example. So, those are self-interest, and therefore, the only way you dismantle them is to ensure that you don't re-elect them. And, it's basically that. But, it's very interesting how people elect people who just should not be there. But, and then they expect a miracle from them. It just doesn't work that way. So anyway.
And on that note.
I
think we'll close the session given the time, and I'd like to take this opportunity as facilitator for this evening to thank you so much for being here this evening. I really do appreciate you coming out. And I'm sure you'll agree it's been a fantastic start to Nursing Week, and an absolute pleasure to have Sheila Tlou with us. So thank you very much, Sheila.
Thank you so much. And let's get out there and move mountains. We still have the energy and the power to do that.
Mountains and men's bodies.
Men's bodies. Right. Thank you.